Okay, hey everyone, welcome to our week 5 PSPirates session. Today I'll be starting off the session by talking a little bit about PHARM and ANS 1 and 2. So to start with what this topic actually covers, talk through the learning objectives and what they mean in sort of simple terms. And so this lecture is really based on a lot of the work you've done understanding the physiology of the ANS and then applying that to drugs and their mechanisms of action. So in simple terms, these learning objectives sort of mean to have a basic overview of, firstly, the branches in the autonomic nervous system, then also the receptors and neurotransmitters, what they are, what they do, and then specifically be able to use this knowledge to relate that to the actions of drugs. So to get started by talking and giving a brief overview of the ANS, talk a little bit about the neurotransmitters in the autonomic nervous system. So we all know that the ANS comprises of the sympathetic and parasympathetic nervous systems, and the sympathetic nerves use acetylcholine or ACH and noradrenaline, and that's what we see in this here. And then you have the parasympathetic nerves, which only use acetylcholine. So just as some baseline knowledge here, things that use acetylcholine will usually be called cholinergic, and then things that use noradrenaline or adrenaline will be called adrenergic. So now to talk a little bit about the receptors in the autonomic nervous system. All the neurotransmitters must act on receptors. So whenever you have ACH acting ACH at a nerve terminal, it must act on muscarinic or nicotinic receptors. And then within these categories of muscarinic and nicotinic, you have subcategories. So within muscarinic receptors, you have muscarinic receptors M1 to 5, and I'll talk a little bit about these later. And with nicotinic receptors, you have neuronal or muscular. With noradrenaline, these act on alpha receptors, and there are 2 types here, or beta receptors, and there are 3 types of those. So just to relate that to this diagram, what you see is that you have somatic innervation, which relies on acetylcholine, which acts on nicotinic but muscular branches. Then you have sympathetic, and the majority of the sympathetic nervous system will use acetylcholine, which acts on a nicotinic neuronal receptor, which then sends off another post-ganglionic or post-synaptic neuron that releases noradrenaline, which then acts on these alpha receptors or beta receptors. But then you have 2 special categories of the sympathetic nervous system. The first is the sweat glands or the eccrine glands, and that uses acetylcholine acting on a muscarinic receptor. And then you also have the adrenal medulla, where you have acetylcholine acting on a neuronal nicotinic receptor. And finally, you have the parasympathetic nervous system, and there you have acetylcholine acting on a nicotinic neuronal, and then acetylcholine acting on a muscarinic. So to continue by talking a little bit about the ANS receptors, it is important to understand what these receptors, where these receptors are, and which sort of part of this sympathetic or parasympathetic nervous system they're actually part of. So the useful thing is that muscarinic receptors are only found in the sympathetic nervous system, except for the sweat glands, which are part of the sympathetic nervous system. And then you also will know that sympathetic nervous systems will usually have things acting on these alpha or beta receptors. So to start by talking about nicotinic receptors, these are the ones that are found at autonomic nervous system ganglia in the sympathetic and parasympathetic systems. So these ones are quite important because they're part of both systems. So these are these ionotropic and ligand-gated protein that activates the influx of Na+ into the cell, and this results in the activation of the receptor. What's important to know about nicotinic receptors is that when their depolarization blockade can occur. And what depolarization blockade means is that when the receptor is activated multiple times, it actually causes in the complete breakdown of the receptor. And what that means is that both an antagonist and an agonist will inhibit nicotinic receptors. Now moving on to muscarinic receptors, we'll find that muscarinic receptors are mainly found in the parasympathetic nervous system, and these are not susceptible for depolarization blockade, which means that the antagonist and an agonist will have different effects. And there are 5 different types of muscarinic receptors. So now to continue by talking about where these receptors are actually found, they have a very complex array of features, and you can see on the left a diagram that shows sort of a more detailed description of what these features are. But what you really need to know is on the right, which is that M1 receptors are mainly found in the CNS, M2 are mainly found in the cardiac tissue, M3 is mainly found in the GIT, or this smooth muscle, and then M4 and M5 are found in the CNS. A nice sort of way to remember this is that as you go down from M1, M2, M3, you go down from the body, the brain to the heart to the gut. So that's how it's going down. Then finally, with acetylcholine removal, you'll see that acetylcholine, once it is released into that synapse, it's rapidly degraded through acetylcholinesterases. And this is also important because it can be a place where drugs act, or drugs act to disable acetylcholine or increase its action. Now moving on to the sympathetic nervous system, you have the alpha receptors and the beta receptors. So the alpha receptors, the thing you should know is that it's located within the sympathetic nervous system. The A1 receptors are mainly found in vasoconstriction, GIT contraction, and pupil dilation. The A2 receptors are mainly found in presynaptic terminals. With the beta receptors, what you have is that the main thing that you need to know is that the beta 1 receptors are found in the heart, the beta 2 receptors are found in the lungs, and the beta 3 ones are found in adipose tissue, and they can cause lipolysis. But here, a nice way to remember these two, B1 and B2, is that you have one heart, but two lungs, and that correlates to which receptor applies to which tissue. Finally, you have noradrenaline, which is a neurotransmitter in the sympathetic nervous system acting on these receptors. And these are removed from the terminal through reuptake, either into the first or second neuronal cell. And there it's recycled to be reused by the cell. And here, interestingly, we'll bring in a little bit of drugs. You get cocaine, which is acting by inhibiting the reuptake of noradrenaline, which means that noradrenaline continuously acts on the receptors, and then you have overactivation of the sympathetic nervous system. So now that we have this brief overview, let's think about how we actually want to use this information. Because I think that when you approach topics like PHARM, it's really easy to get overwhelmed and try to memorize different drugs. But really, when you simplify it down, all you really need to know is the actions of the sympathetic and parasympathetic systems, which is quite intuitive if you think of it in terms of like flight or flight, or rest and digest. And then also you need to think about whether a drug enhances or inhibits these actions. So then once you know these things, then you can get on to memorizing things that might be specific to individual drugs, which is much easier to memorize and much more palatable. So now we'll get on to that intuitive first part of this system, and it's easy to relate these actions of the ANS with the flight or fight, or rest and digest. So to remember everything, just use the acronym dumbbells, which applies to the parasympathetic nervous system. So you have DUM, which stands for diarrhea, urination, meiosis, BBE, which stands for bradycardia, bronchoconstriction, and emesis, which is vomiting, and LLS, which stands for lacrimation, lethargy, and salivation/sweating. So with all of these things, you know that parasympathetic is going to be on one end and sympathetic is going to be on the other opposite end. So if you have diarrhea for the parasympathetic nervous system, you know that the opposite of that is going to be constipation for the sympathetic nervous system. And the way I like to think about this in a really easy way, so I don't have to memorize anything, is that you just want to think about what would happen if you were running away. So flight or flight, aka your heart rate would rise, your lungs would expand to let more air in, your smooth muscle tissue would get more blood so you can do more things, as opposed to what would happen if you were resting. So for example, if you were resting and digesting, you would have more activation of your gastrointestinal system. You would also have your heart rate slowing down because you're resting. And you would also have bronchoconstriction because you don't need as much air in your system. So if you think about it in that way, it becomes really intuitive what the actions of the ANS are going to be, especially the separate sections. And this is just two images from your lecture, which relates the receptors to what organ in the body they actually relate to. And these, unfortunately, you do have to somewhat memorize. But as I said before, you can sort of memorize it as in B1, B2 is B1's for the heart, B2 is for the lungs, and you have A1, A2, and A3. And then you can, A1 and A2, and you can sort of think about those as well. So now that we understand that, the rest of the topic comes together really easily. So what you have is this idea of anticholinergic and cholinergic toxicity. So cholinergic toxicity is when you have overactivation of the parasympathetic nervous system, aka you have too much ACH, which is activating a lot of the parasympathetic nervous system. So then you get the dumbbells effects that we talked about before, and this is an image that just summarizes that. Then you have anticholinergic toxicity, which is the opposite of that, and therefore the effects of that are the opposite of dumbbells. So now we get to the drugs of the autonomic nervous system. And I think the best way to approach these is just by remembering the drug and its mechanism of action, and then using that information to understand what effect it would have. So now we'll get onto this sort of meaty part of the lecture. And I won't bother going through all of these drugs, but it's important to just think about what types of drugs they are, and therefore the action and what they do comes together quite intuitively. So I won't bother reading through all of these, but for example, what I would do for each of these drugs is that you have the name of the drug, progestimine, I think, and then you have what type of drug is it. So it's an anticholinesterase, which means that therefore it's going to be inhibiting the actions of acetylcholine, which is going to, it's going to inhibit the actions of acetylcholinesterase, and cholinesterase is the thing that breaks down acetylcholine, which means that there'll be less breakdown of acetylcholine, which means that there'll be an increase in the actions of the parasympathetic nervous system. So when you think about it like that, it becomes very, very easy to understand what each of these drugs will actually do. And there is just a couple of extra slides about, these are the tables that are in your core drug list. So it will be important for you to sort of think about each of these drugs and understand at least these two connections, so hyoscine, for example, and what it is, so an antimuscarinic. And then after that, you don't necessarily have to memorize what it actually does, except for perhaps special notes, such as it acts in the CNS rather than in the GIT itself. And here on this slide, you have the adrenergic drugs. And here, similarly, you have these ideas that these drugs are alpha blockers, and therefore there's a set of effects that happens as a result, because you are either decreasing the activation of the sympathetic nervous system, or you're increasing the action of the sympathetic nervous system. And finally, just as a note, since acetylcholine and nicotinic receptors are present in both the sympathetic and parasympathetic systems, the underlying tone of the system is important to understand the influence of drugs. So what this means is that since acetylcholine is in both the sympathetic and parasympathetic systems, you don't necessarily know what will happen if you remove acetylcholine, because it's important in both systems. So what happens as a result is the actual tone of the organ or system that is being blocked is actually quite important in this case. So here, anticholinergic and anti-nicotinic drugs will decrease the underlying tone of a system. So for example, the heart has a baseline vagal or parasympathetic tone. So as a result, providing a nicotinic ganglion blocker, aka reducing the action of acetylcholine, will decrease parasympathetic tone and increase the heart rate. But for example, if the heart was stressed and it had a baseline sympathetic tone, providing the same drug would actually decrease heart rate, because it would be decreasing the normal sympathetic tone of the heart. And the reason that is the case is because the natural tone of the thing is what uses acetylcholine more. So therefore, reducing acetylcholine in the more predominant tone of the system will work against that system and reduce the tone. And that is it for ANS and PHARM.
Okay, so I'll be taking you through lower limb, but I know you all will understand it so well now because you've done the upper limb and it's pretty much just a repeat of that, just in the legs. So these are the learning objectives, and I found like how I did my anatomy is like I wrote all these learning objectives down and then like summarized like the key points underneath this, and it's like made it really helpful for when I came to exams to like revise. So yeah, and if you hit all these learning objectives, then I think you're doing pretty well. So to start with, we'll look at the hip. So it's the fusion of 3 bones, and this is also termed the os coxae. So the ilium is the most superior, and then you have the pubis at the front, which forms the pubis symphysis at the front, which you can feel, and then you have the ischium underneath. And when you're sitting down, that's what you're sitting on. And all these 3 bones join just here in the acetabulum, if you can see my mouse. And so the hip forms two joints. This is the sacroiliac joint here, and this is the hip joint, which is formed between the femur and the acetabulum. Oh, and sorry, so I'll just go back. So I just want to point out some important bits to know on the hip. So just definitely make sure you know where the anterior superior iliac spine is, the anterior inferior iliac spine, and then the ischial spine in here. And also know where the ischiopubic ramus is down the bottom, and the acetabulum, because this is where like a lot of key important ligaments and structures and muscles attach to. So moving on. So some major landmarks on the femur. So you have the femur head, which you can't really see in here because it's sitting in the acetabulum. And then you have the neck. And on the top of the acetabulum, there's actually like a little like fossa kind of thing called the fovea capitis. And this will be like an attachment point, which we will see a bit later. And then you also have the greater trochanter and the lesser trochanter. And just like point out that this is actually on the posterior of the femur. So like to try and like orientate yourself when you're looking at these, they're on the back of the femur. And then you have this gluteal tuberosity on the back as well, and that's where your gluteal muscles will attach. And then you have the lateral and medial epicondyles and condyles. So the lateral and medial epicondyles are, if I like tried to like describe it, they're on the side, and that's like major points for like muscle attachments, whereas the condyles are more what actually articulates with the tibia in the knee joint. Okay, and so moving on to the ligaments. Most of the ligaments of the body are named after their origin and insertion. So like a lot of them you can just derive, like the sacrotuberous ligament, it runs from the sacrum to the tuberous, and then the sacrospinous, it runs from the sacrum as well to the spinous process. So you can see all these other ones here, the inguinal ligament, and the lacunal ligament is just a little ligament in there, but that's pretty irrelevant. Except, yeah, so that's about it. All I had to say for this is that the sacrospinous and sacrotuberous ligaments help form the greater and lesser sciatic foramen, which carry important neurovascular and muscles through them. So keep these in mind, and we'll go through that a bit later. So now these are structures that support the hip joint. So this black line is the acetabular labrum, except you've got to imagine that it's actually coming out. So it's actually like a bit thicker. So it's going onto the femur to protect the hip joint. And then, yeah, this was probably all run through in your lecture, but the iliofemoral ligament. So as you can see, you just got to really read the name because it's coming from the ilium and going to the femoral, femur, sorry, whereas this one's coming from the pubis and running to the femur. And like another good way to remember it is that the iliofemoral ligament is the only one that splits into Y shape and has like two insertion points onto the femur, if that's a good way to remember it. And this is just a little point onto the side that the inferior part of the capsule is least reinforced, as you can see down here, and that's why it's most prone to dislocation. Yeah, and also because the acetabular labrum is thicker on its anterior part, which is why this posterior bit is also more prone to dislocation. Okay, so blood supply and fractures. So the main blood supply to your thigh area is via the femoral artery. And this branches pretty early on into the deep profund, like into a deep branch. And so profunda just means deep down here. So it's just a deep femoral artery. And these give rise to the lateral and medial circumflex arteries. And the importance of this, and like, I feel like they pretty much like drill this into you, and you know the points that they drill into you, like remember these because that's what they'll ask you about. So these are like, if you have a fracture of the neck of the femur, of the head of the femur, what will happen? And so what they're trying to get at is that if the fracture disrupts the blood flow, then there's like a really high chance of like avascular necrosis and this part of the femur dying, which means you'll need a hip replacement. And so this is just a little mnemonic to remember the different types of fractures or breaks. And so it's just sit the baby in the sun, good lad, and good lad stands for greater trochanter and lesser trochanter fractures. So yeah, and this will, yeah, I feel like what really helped me is like drawing down yourself, like the arteries and like labeling them as you go. So like drawing the femoral artery and then putting in its branches really helps you like conceptualize in your head, so that if they do ask you a clinical question, you can try and work out what they're talking about, instead of just memorizing specific things like, I don't know, the medial femoral is just there. So I feel like if you understand it more holistically, it's easier to apply it to the clinical questions they'll ask you. And so moving on now, we'll go through the muscles of the thigh compartments. So these are just some of the actions that we will be going through. So flexion is obviously moving the leg forward at the hip joint, extension is back, abduction is out, and adduction is as if you're moving your leg across, as you can see here, and then external rotation is if you're moving your foot outwards to the side, and internal rotation is inwards. And so with this, I just did it all in compartments, and I think that compartments make it easier to remember. And once you actually compartmentalize it, you will see that there's a common vasculature, nerve, and function of the muscles contained within. So instead of like trying to remember every single muscle, you can just say, oh, this is part of this compartment, and this is the artery or nerve that supplies this. And don't get too caught up on the nerves at the moment, because you'll get like another lecture down the track on the I think it's a sacrolumbal plexus, and that will like make these nerves make a lot more sense. But just as I was saying before, like a really good tip I would say is to like draw it all out, and that helps to remember it. Okay, but so starting off, you have the short rotators. So first you have the piriformis up here, superior gemellus, obturator internus, inferior and quadratus, and then the obturator externus runs from the outside. And a good little tip that I know is the gemellus muscles always hijack the nerve from the muscle below, so they don't ever have like their own specific nerve running to them. And so these are the adductors in here. So you have the adductor brevis, which, as you would know from your hand, like upper limb anatomy, that brevis means it's shorter, longus means it's longer. And then gracilis runs down in the front here. And then you have the obturator externus. So you'll notice that some of these muscles have a little bit of overlap. So obturator externus is also a short rotator and an adductor. And then you have adductor magnus, which is a really big muscle that looks more like a fan. And so moving on, these are the adductors, or abductors, except excluding gluteus maximus, which is more of an extensor of the hip joint. And these are pretty easy because they're all innervated by the superior gluteal nerve. And as you can see here, you can see that they insert on that gluteal tuberosity that I was telling you about in the femur. Oh, and greater trochanter, sorry. And so these are the anterior part of the leg. So these are involved in flexion. And so here you can see that you have the psoas major and minor, which run down from the side of the spine or the sacrum down into down and touch on the femur. And then you also have iliacus running down here and pectineus in this little area as well. And then sartorius runs around the front as goes from lateral to medial, and gracilis is down here. And then with these ones, the quadriceps are formed by, I think it's there's three vactus muscles. So there's a medial underneath this one, there's like a intermediate and a lateral, and then this is the rectus femoris muscle. And so they all form the quadriceps, which are the flexors of your hip joint. And some of these they like to test you about, because if you cross over two joints, then you're actually having two functions. So the quadriceps help to flex the hip, but then they also help to extend the knee joint. So that's like a little bit of a trick that they might get asked about. And these are the extensors, so help pull the hip joint back. And so you have the gluteal maximus, semimembranous, semitendinosus, and the biceps. So yeah. So this was the lumbosacral plexus I was telling you about before. And yeah, it's just, all I can say is memorize it, and memorize these like the areas that they come from, because we did get asked a few questions on this. So like know that the femoral nerve has L2 to L4 branches in it, if that makes sense. So yeah, I don't really know how else to say this other than just memorize it. And there's a mnemonic there that we were taught from a PSP last year. So it's I twice, so 2 I's, G get laid on Fridays, and then you know that's that top part, and then you have the superior inferior gluteal nerve and the sciatic nerve. And don't worry too much about the sciatic nerve, because it will make more sense, like the fibula and tibular division, as you get into the lower part of the leg. But the 3 main nerves for the thigh would be the femoral obturator and the sciatic nerve for innervation of the muscles. And so this was this compartmental idea that, like, just in another diagram that I was trying to get to. So as you can see here, that all the muscles on the medial part, so in here of the leg, they would all do adduction, and you can see that they're all innervated by the obturator nerve, which makes it a lot easier to remember, except there's always an exception, this abductor magnus, which has a tiny tibial portion. And so yeah, this is a helpful diagram with those arteries that I was telling you about, so just going through and drawing that I hope will help. But moving on to lower limb 2, so now we're moving on to the lower part of the leg. So you can see here you have this is the tibia and this is the fibula, and the tibia is what articulates with the femur to form the knee joint. So the fibula doesn't articulate at all in that joint. And just important to note, the patella doesn't articulate with the tibia, it only articulates with the femur. And there's just a few other little points, that it's a sesamoid bone, and that it is a plain type synovial joint. So moving on, I actually struggled so much last year with doing the posterior cruciate ligament and anterior cruciate ligament, like understanding in my head where they ran. So I might just move on to this one so that I can try and explain it a bit better here. But so a little mnemonic, it's called PCL, or for your posterior cruciate ligament, it's called PHARM. So it means it's going from posterior to anterior, lateral to medial. And so if you imagine it in this way, that it's going posterior to anterior, where it's attaching on your femur, that is why that on a fixed femur, wait, let me get this right. Oh, yeah, so on a fixed femur, you're limiting posterior displacement of the tibia, whereas on a fixed tibia, you're limiting anterior displacement of the femur. So like really, all like the functions of these ligaments will make sense if you understand where they're running from. So yeah, pretty much if you understand that it's running from posterior to anterior, lateral to medial, then you know when you're doing those tests in the exam what their function will be and what they're stopping. And so as you can see here too, the lateral collateral ligament and the medial collateral ligament. So the lateral collateral ligament prevents varus, which is as if the knees, if this is like the hip up here and the feet down here, which is preventing the knees from doing this. And you could probably just like work that in your head, because lateral, they're stopping the knees from pushing out. Whereas medial, they're stopping from pushing in. So it'd be as if your knees are going in like that. And just like, yes, that's termed valgus. And a way that we were told last year that you could remember it is valgus has an L in it. And so if you're pushing in like that, you can imagine that your legs form like an L shape. And so, yeah, anyway, I hope that helps, but that's just a little way to be able to remember it. And so, yeah, this unhappy triad is like a pretty common thing that they drilled into us as well. So it's just because there's a common insertion of the ACL, medial meniscus, and the medial collateral ligament, or that they're all connected, that any like pressure will result in this unhappy triad. And that obviously is a lot of damage in the knee. And so these are the bursae. Honestly, I can't remember being tested on any of these ones down here. It was just something that that we had to know. But yeah, so obviously the bursae are critical for smooth and frictionless motion. of the joints and they can be inflamed. So bursitis is when the bursa get inflamed. And there's also a bursa on the lateral part of the knee, and it's called the pes anzuri bursa. And it's underneath the goose's foot attachment. And so this attachment is the combined tendon of gracilis, semitendinous, and sartorius. And a way to remember it is to say grace before T, as if you're going anterior to posterior. So the sartorius is first, and then the gracilis, and then the semitendinosus. And I think out of all the bursa, that might have been the only one that they questioned us on, just because it does form that common attachment. So yeah, moving on to the popliteal fossa. So this is in the posterior part of the knee, and you can feel your own popliteal fossa on yourself. And you will get shown in Clin skills like how to feel for the popliteal artery as well. And so yeah, they're just the contents that would run through it: popliteal artery, popliteal vein, tibial nerve, and common fibular nerve. So these two are branches of that sciatic nerve that we looked at before. Okay, so these are movements of the lower limb. And I can't tell you, I was so confused for the first part because like we did not go through this. And every time they were talking about flexion, I thought it was going to be to go forward. But no, flexion is, how I see it, is the opposite of what it is everywhere else in the body, because flexion's actually going backwards. But so yeah, I just thought I'd point that out. But otherwise, they're all pretty self-explanatory. With the inversion, it's as if you're like rolling in on your foot, whereas eversion is going out. And with this lower limb as well, you'll notice that I've done it into 4 compartments. And yeah, it's the same, like that it has the same innervation and like muscle function in these compartments. So I hope that helps you like remember them and group them. So for the anterior compartment, you can see that this is the tibialis anterior, so that inserts onto the medial aspect of the foot. And then it's the same as with the hands. You have the extensor hallucis longus. So you know that hallucis is associated with like the thumb or the big toe. So that's why it's going down and only inserting on the big toe, whereas digitorum inserts on all the others. So you like, if you like read the name, I suppose it really tells you a lot about the muscle. And then this is the lateral. And with these, just keep in mind that they run close to this lateral malleolus, and this will be important for contents that go through the tarsal tunnel and then tarsal tunnel inflammation. But I've got a slide on this in a minute. So yeah, and like the same thing, brevis is always the shorter muscle. So if they've given you the muscle and they say identify which one it is, you will know which one brevis is because it'll be the shorter one, and longus will be the longer one, sorry. And then so this is the posterior compartment is divided into superficial and deep. And so the head of the gastrocnemius would actually run over here, but then you have plantaris and soleus, and they form this common like Achilles tendon, which can also be known as calcaneal tendon. So yeah, so this is the deep posterior. I don't really have anything to say about them, just the same thing. So digitorum means it would be inserting on all the digits except the big toe, whereas the flexor hallucis will just be inserting on the big toe. So pretty much just the opposite to what the anterior compartment of the lower leg looked like. Okay, so this is the tarsal tunnel, and I do remember them drilling this into us a lot, but I can't remember if we got a question on it. But this is a good way to remember it is Tom, Dick, and very neurotic Harry. So you can see like tibial tendon, digitorum, artery, vein, nerve, and the hallucis. So yeah, and the importance of this is like if there's any pressure buildup or anything in there, then obviously you're going to get compression of the nerve or pain. And so pretty much the only way to fix this is by cutting this flexor retinaculum, which is the exact same as the carpal tunnel in the hand. But so yeah, and so next week in the lower limb 3, we'll be moving on more to the foot and the bones, muscles in there. But I'll just pass on now. Did you want me to stop sharing or keep going?
I don't mind sharing it.
Okay, I'll stop mine. Oh, and just if anyone has any questions to message me.
All right, so I'm just going to be doing the intro to ANS. Emil covered basically like a lot of what I'm going to be talking about today. But I guess I can provide another kind of overview. So what you'll notice is with the ANS, the physiology and the pharmacology kind of go hand in hand with each other. So the greater knowledge you develop in PHYS, it will make your PHARM easier and vice versa. So the general organization of the nervous system, if we look at it, the autonomic is actually only a small branch of it. You've got the CNS, which is brain and spinal cord, and then you've got the peripheral nervous system. And then that can be further divided into sensory and motor. And sensory is separate. And then among the motor division, that's where we have our autonomics. So autonomic kind of reminds you of automatic. So you do it without thinking. So it's basically involuntary responses. So the autonomic nervous system can be divided into sympathetic and parasympathetic. And as Emil kind of said, we've got the fight or flight, or the rest and digest, which is parasympathetic. So, I mean, we've already seen this image, but just one more time. Parasympathetic nervous system. Think about resting and digesting. What's important for digesting food, and for sympathetic fight or flight, what's important for kind of being active. So I guess when you're active or when you're running away from something, you want to have as much eyesight as possible, or as sharp eyesight as possible, so pupil dilates. You want more blood pumping to your muscles, so that you can run faster, so your heart increases its heart rate. Your airways dilate so you can get more oxygen in, so you can keep running. Your sweat glands are open, so you'll notice that when you're exercising, you start to sweat. That's a result of the sympathetic nervous system. Your liver increases the rate of glycogen to glucose, so you're getting more energy to keep going. So it kind of makes sense, right? So, and your stomach, your uterus, your urinary system, they're all going to relax and focus more on putting the effort into your heart and your airways, basically. Parasympathetic is the opposite, so your digestive system kicks into gear when that's activated. You start digesting the food. Urinary system can increase its output. Airways constrict because you don't really need as much oxygen. That's why after a meal you often feel kind of sleepy, because you're getting less oxygen, because your PSNS goes into overdrive, and so you're getting less oxygen. Your heart rate slows down. You feel a bit more tired. That's normal. So, one key thing that you're going to learn, especially in PHARM, so this is more important for PHARM than it is for autonomic nervous system, but what we're going to learn is the difference between a pre and post ganglionic fiber. So in the autonomic nervous system, we've got kind of two pathways. So you've got from the actual CNS to the ganglion, and then from the ganglion to where they want to take effect. Okay, so if what you've learned so far with somatic motor is that CNS goes straight to the skeletal muscle. I want to contract my arms. Okay, I'm going to contract my arms. Autonomic nervous system is not like that. So you're going to have ganglion. Now, you don't need to know too much about the ganglion. Honestly, I don't even know that much still. But what you do need to know is that pre-ganglionic neurons are myelinated. So myelinated means they can go faster because they've got the myelin sheath around. And postganglionic neurons are unmyelinated, so they're a bit slower. The other thing you need to know is that sympathetics have a really short preganglionic neuron and a long postganglionic neuron. So you can see it kind of in the top image. With the sympathetic, it stops, it gets to the ganglion it's much faster, so it's a shorter distance. Whereas for the parasympathetic, the distance is quite long. Actually, the ganglion is usually really close to the target fiber. So that's probably the main thing. So one is preganglionic is myelinated and postganglionic is unmyelinated. And two is that sympathetics have a really short preganglionic neuron and parasympathetics have a really long preganglionic neuron. Okay. So what are the parasympathetic things? Now, you might be confused as to what cranial nerves 3, 7, 8, 10 or S2 to 4R. It's not really a big deal. You more or less need to know that parasympathetic is from the craniosacral division and sympathetic is from the thoracolumbar division. Now, that's basically it. And in terms of where they originate from, don't confuse cranio with cervical. So it is, cranium means like close to the brain, not like spine where cervical is. So that's the confusion that a lot of people make initially. But yeah, that's all you need to know really. Parasympathetic is craniosacral and sympathetic is thoracolumbar. And yeah, what I was saying before about the ganglia lying close to the organs in parasympathetics, and in sympathetics, the ganglia lie close to the spinal cord. So yeah. So again, you probably already heard this from Emil, but the main neurotransmitters are acetylcholine and noradrenaline. The way I used to remember it is adrenaline, like why would I have adrenaline if I'm just resting and digesting? It's more for like excitatory events. So that's going to be used more or less for the majority of the sympathetics. Now, acetylcholine is still used in both, but the main neurotransmitter for the sympathetics is noradrenaline. Acetylcholine is going to be talked about a lot going forward, but basically it's released by all preganglionic neurons. So remember how I said that there was I'll go back. So in this image, you can see that there's a preganglionic neuron and a postganglionic neuron. So acetylcholine is always going to be that preganglionic neurotransmitter. And then once it reaches the ganglion, which is here and here, it's going to switch. So in the parasympathetic, you're going to release acetylcholine once more. And in the sympathetic, you're going to release noradrenaline or norepinephrine. It doesn't really matter, it's the same thing. But yeah, that's basically all you need to know. And in somatic nerves, all body muscle nerves, you're also going to be releasing acetylcholine, so you should be pretty familiar with that already. And the pathway of its release from the end of the axon.
Okay, so I'll talk about the central nervous system's control of the ANS. So Emil and Pranay have talked about the ANS pretty well, and this is not really going to relate to those things, more so how our brain and like the higher centers control that. So on the next slide, yeah, so we have 4 different parts of your brain, or like higher up, that will control your ANS. So we have the cerebral cortex and the spinal cord, and those are they're not as relevant for this in your lecture and in this topic, but just know that spinal cords, and you're probably already familiar, that they're often involved in reflexes. So the afferent will go from like your hand to your spinal cord, it'll relay onto an interneuron and then go onto an efferent nerve and like contract a muscle, so you take your hand away. And then we have the hypothalamus and the brainstem. Those are the 2 main ones that we'll talk about. And the hypothalamus is the really main one. So it's often referred to in the lecture as the big boss, because it controls a lot of your autonomic nervous system. Okay, so with the hypothalamus, yep. So there's 5 key functions. Pretty much all of them relate to the main function of the hypothalamus, which is maintaining homeostasis. So it'll kind of get information from other parts of your body and your bloodstream and stuff, and then get and then regulate different hormones and regulate your body to kind of balance any changes that happen. So you have 5 main functions. You don't really need to know actually at all how your hypothalamus accomplishes these, but these are the main ones that you should be aware of. So it's going to control your blood pressure and electrolyte composition. So things like how much sodium and potassium and stuff is in your blood. It's going to regulate your body temperature, and it's going to control your metabolism. it's involved in producing certain hormones that will regulate things like your menstrual cycle, so affect your reproduction. And then it will also control your response to stress. And in terms of inputs, so as I mentioned before, it gets inputs from lots of areas of your body. And that is just so it can kind of keep an eye on whether or not it needs to change anything to maintain homeostasis. So sensory information and hormones are the main ones. So if there's any big changes in the hormone levels in your bloodstream, your hypothalamus can respond to that. And then other places like your cortex and your limbic system, that'll contribute things like thoughts and emotions. And then your spinal cord can also give some information. So there's 3 main nuclei that you should be aware of in the hypothalamus. So the word nucleus is often used in like a lot of different ways in med. So when we're talking about like what's a nucleus in a brain, it's just referring to a collection of neurons in your brain, and they're usually responsible for certain functions. So they could be like sending certain signals in response to certain inputs the hypothalamus gets, or releasing certain hormones or stuff like that. So there's 3 main ones. There's the paraventricular, the suprachiasmatic, and the dorsomedial. Don't worry too much about the zone and region, but just be familiar with the functions. So the paraventricular, this is kind of involved in fluid balance as well as milk letdown. So releasing milk from where it's produced and stored into the ducts. And then parturition, so that's childbirth and controlling contractions involved in childbirth. And then kind of what we're talking about with controlling the autonomic system as well. And then also the anterior pituitary, which is just a part of your brain that releases a bunch of hormones to regulate different functions. And then the suprachiasmatic, it is responsible for managing your biological rhythms. So when you're feeling awake, when you start to feel sleepy at the end of the day. And then the dorsomedial is related to things like emotions, especially things like rage. Okay, and then I've just chucked this in there for anyone who wants to know what those zones and regions are, but you do not need to know this at all, and you'll never get asked about it. So don't bother. Okay, and then the brainstem. So it's kind of called the male sorting center, and I think that's what he refers to it in the lecture as well, because it's taking information from above, like how we mentioned before, takes information from the hypothalamus, also can take information from below, so things like the spinal cord, and it's going to decide where to distribute it. And it's really important in terms of the autonomic nervous system, because a lot of autonomic nerves, specifically parasympathetic ones, can originate from the brainstem, and a lot of the sympathetic and parasympathetic outflow come from that area, the brainstem. So these are 4 key things that it's involved in, and this is not a very exhaustive list, and also you'll come across a lot of these as you learn about the cardiovascular system, as you learn about the respiratory system, but just be familiar. So with the cardiovascular center, that's going to control things like your heart rate and the force of like how hard your heart is beating. And as you can imagine, that's controlled by the sympathetic nervous system, which will increase your heart rate, increase the force of contractility, and then the parasympathetic system, which will do the opposite. And then the respiratory center, in a similar way, is the sympathetic will increase, the parasympathetic will decrease, or it might be the other way around. Okay, anyways. And then the micturition, urination control, you'll learn about that next year, so don't worry about how, but just be aware. And then there's also what you'll see coming up a lot actually is a parasympathetic nerve called the vagus nerve, and that also comes out of the brainstem, along with a few other ones as well, but vagus is the one that you'll come across the most. And then, so we have 3 key sections. So we have the midbrain, which is the one at the very top, as you can see in the photo, and then the pons, which is in the middle, and then the medulla down the bottom. So again, the lists of like what each one does, it's not a very exhaustive list, but it can give you an idea. The main one I would note is the medulla, which is the one that controls all your vital functions, like your heart rate and your breathing, and also controls some reflex actions in your breathing and also in your GIT. And then there's two key structures in your brainstem that will come up. So there's the reticular formation. So that's just a bunch of nuclei that we talked about before, that all just connected, and they're located throughout the brainstem. And they have a really direct, or the most direct influence over autonomic function out of the other structures in the brainstem, because they influence the sympathetic and parasympathetic neurons that are traveling out of the brainstem and out of the spinal cord as well. And then the rostral ventrolateral medulla is another structure. So this one is the major, like where a lot of the sympathetic nerves, preganglionic neurons come out of before they enter the spinal cord. So those are just the two main ones.
Hi everyone, welcome to this week. We're going to be covering discriminative somatic senses. First of all, somatosensory receptors are endings of nerve fibers that can be identified by location and encapsulation. The four that I'm going to be talking about are Pacinian corpuscles, Meissner's corpuscles, Merkel's discs, and Ruffini endings. We're going to learn about where they are in the layers of the skin, what they detect, what kind of nerve fibers they're made out of, how fast are they to adapt to changes in the stimulus. And these are going to be important because we are able to identify what receptors are damaged in the clinical setting. First, a recap of perception. We've got peripheral nervous system and central nervous system. Peripheral nervous system takes care of moving stimulus and interpreting that information, sending it to the afferent neuron. And the central nervous system interprets information from the spinal cord and sends it to the cortex. Well, essentially, the cortex is the one that's interpreting. All the other things in between are just transporters of the information. There are also 4 classes of sensory neurons, A alpha, A beta, A delta, and C fibers. If you have a look on the right, conduction velocity in that column, you can see that it is slower as you go down. And some of them are myelinated. That means it's faster. Some of them aren't. That makes sense why the unmyelinated ones are slower. Some of them are wider and they carry different information. A good tip on remembering which one's fast and which one's slow is a delta plane is fast, but a cab is slow. Therefore, A delta fibers have fast conduction velocity and C fibers have slow conduction velocity. And then A alpha and A beta are even faster. Mechanoreceptors. Out of Meissner's corpuscle, Merkel cells, and Pacinian corpuscle, we can see that they have different neural spike trains in relation or responding to the same stimulus. So the receptors adapt to the stimulus and the level of adaptation varies accordingly to the depth of the receptor. The Pacinian corpuscle is a lot deeper. Therefore, with the stimulus right here, say this is like something touching your hand. It will detect that something has changed. For example, something's touching your hand, but then it will stop firing. What happens here is deep receptors adapt faster. And so even though the stimulus is still there, energy is shifted away from the receptor telling us that there's a stimulus, because it already told us before, and it no longer responds to the stimulus. There's only one other firing motion when the stimulus is removed. Mechanoreceptors and receptive fields. So here we can see the locations. Meissner's and Merkel's are superficial, and the Pacinian corpuscle, as well as the Ruffini corpuscles, are deep. We can also see, or a way to remember this, is that mechanoreceptors beginning with M, Merkel discs and Meissner corpuscles, are located in the superficial layers of the skin, while those whose name contains ini, Ruffini corpuscles, and Pacinian corpuscles are located in the deep layers. I have copied and pasted this image into a lot of the slides just so that we can keep referring to it when we look at each of the nerve endings. First, Pacinian corpuscles. It's located in both non-hairy and hairy parts of the skin in the subcutaneous tissue. It adapts really quickly. The fiber types include A alpha and A beta, therefore fast. And the type of sensation is pressure and vibration. And we can see them right here. Meissner's corpuscles are located in the non-hairy glabrous skin, rapidly adapting as well, A alpha and A beta, but instead of pressure and vibration, they sense proprioception, which we'll talk about, and dynamic, fine, and light touch. Ruffini endings, right here, are located in both non-hairy and hairy skin, especially in the fingers and toes. It's slowly adapting, therefore slow to detect changes. And it senses stretching of tissue, pressure, and changes in joint angles. Next, we're going to move to proprioception. So here in this diagram, we can see the sort of geographical relationship between the joint receptors, Golgi tendon organs, and neuromuscular spindles. And we can see that they're not in the superficial layer in the same way that Ruffini corpuscles and Pacinian corpuscles are. They seem to be deeper inside the body, in this case, the upper limb. So proprioception gives us information about position and movement of limbs and body in space. That is, movement of limbs without seeing them. And examples of this include walking, and you're moving your legs, or sometimes even moving your arms, but you're not looking at your hands to move them. You can look forward and you trust that they are moving where you want them to move. If you're able to do that, that's proprioception. And if you have to look at your limbs to know where they are in space, that means one would lack proprioception. Skin receptors respond to skin stretch, and they terminate along the collagen fibers of the skin. And joint receptors they're not essential, meaning that they can be removed for procedures and it won't harm sensation. Let's compare muscle spindles with the Golgi tendon organ. Muscle spindles are in the skeletal muscles, whereas Golgi tendon organs are in the tendons of skeletal muscles. And muscle spindles perceive length and change of muscle length. That is, for example, muscle stretching. So think of that like the length, it's physical, whereas the Golgi tendon organs perceive muscle tension. Think of that as more physiological. And so the purpose of the muscle spindles are to contract the stretched muscle, whereas the Golgi tendon organs relax the muscle before tendon damage occurs. And examples of this include taking a reflex hammer and tapping it on a tendon to cause a contraction versus the sudden relaxation in a weightlifter when they're using extremely heavy weights. Joint receptors. They are various structures that allow for measurement of joint capsule stretching. For example, free nociceptive nerve endings and Ruffini corpuscles. They are located in the joint capsule and they are activated by stretching of joint capsule. And that's all from me today.
So last thing to wrap us up for today, nice and quick, we're going to go through a bit about neurohistory. So if you just want to go to the next slide. Yep, so a lot of the stuff that I put in here today, it's like quite well summarized in Rahman's notes and Brittany Pham's notes as well. So these next few slides are basically more so for you to just have a place that you can go to for like a bit of a summary, because, you know, with Clin skills, a lot of it is mostly just putting it into practice. But yeah, so with the next slide, this is just kind of a list of different things I suppose like when you hear about these things, you're going to be like, oh, okay, kind of recognizing this probably has to do with neuro, or it could potentially have to do with neuro. A lot of these things are like symptoms we're about to go through, but just in particular, things, for example, such as like a head injury where you have loss of consciousness. That's not specifically like a symptom of any kind, but that's something where you hear about a head injury and you'd want to kind of link that to potentially there's some neuro damage there. Yeah, so just moving on. Yep, so we'll start off with our systems review for the CNS, so the central nervous system. You've got those 3 different categories there. So you've got where it's specifically brain related, the injury or the problem. You've got sensory related, and you've got the meninges. And the meninges are the membranes. I think there's about 3 of them that cover your brain itself. So when we're talking about brain related symptoms, you can see things like headache, loss of consciousness, drowsiness, fainting, dizziness, vertigo, and fits and seizures. For sensory, you've got things like a disturbance of the senses. So we're talking about things like difficulty with eyesight, maybe a loss of taste or difficulty with smell, those sorts of things. And then when we're talking about meninges, that can have symptoms such as neck stiffness or photophobia, where you've got like sort of you're not able to take in the light, so then your eyes, you're struggling with seeing, you're very sensitive to the light. And with all of these here, they're quite common symptoms for a lot of neuro things. A lot of things will be related to the CNS, but it is just important to go through all these different categories as well and try to remember for when you're in your clinical placements and when you're going to start working, I'm just thinking about what it could potentially be related to, depending on what kind of symptom you're seeing. So if you're seeing neck stiffness, being like, oh, okay, that might be meninges damage. Yep, so next slide, then we're going to go into the PNS, which is the peripheral nervous system. You've got these 2 categories here for this. You've got sensory and motor. So for sensory symptoms, some examples are numbness, tingling, pins and needles, burning, and like anesthesia, paresthesia, so not being able to feel there. And then you've got motor, so that can be abnormal or involuntary movements, such as like tremors. You can have stiffness and issues with gait. So gait is the way that someone is walking. And then moving on to the ANS, so the autonomic, that can be symptoms such as color changes, so in the skin, so like someone's very pale, something like that. Temperature changes, sort of sweating, and bladder and bowel dysfunction. So that's connected to the nerves within that system. And that's something that a lot of people can trip up on. So that's always important to remember. Sometimes you can feel like, oh, maybe it's to do with the gut instead. And of course, it will be related to the gut, but it's very possible that it's to do with the autonomic nervous system as a whole as well. Yep, and this last slide here, just a couple of notes to remember. So the first point here is that if you're having a bit of trouble distinguishing between the CNS and the PNS, as I said, those brain-related symptoms will always sort of lead you towards the central nervous system. Of course, there's going to be some overlaps at times, but that's just something to look out for. And that last point there is if you're having a bit of trouble between whether something is related to musculoskeletal in terms of like what kind of system review questions you want to ask, compared to like peripheral nervous system or just neuro in general. If you're finding sort of sensory symptoms, so if you want to have a look back at PNS, so that's things like the numbness and the tingling, that's kind of your sign, I suppose, to go into more of the neuro side of things. But that being said, whenever you're doing like an OSCE or any sort of examination like that, or taking a history, it's always good to get multiple systems questions out, because then that way you can rule things out, you can find a proper diagnosis, but then also that way you're able to find out if more than one thing was affected, which is always possible as well. Yeah, there wasn't too much to cover for the neurohistory today, but if you have any questions about that or anything with clinical skills at all, feel free to message me on Facebook as well. But yeah, I think that's all done for today. So yeah, thank you so much for watching. And yeah, we'll see you soon.
Good job, guys. See you soon.